Good evening, friends. At the outset, I would like to thank BFI for inviting and letting discuss about the aortic valve implantation without any open heart surgery. So I think before we started our trip, Dr. S K Mathur and Dr. Mathur asked me that why have you said it like minimalistic TAVI, and my answer to him was like in a very what we call simile in this world, that minimalistic TAVI is nothing but it is like a PFI CME. Every week you get tired, bored, exhausted, and then you need to rejuvenate, and you look forward for a Wednesday evening meeting. So every tired doctor of this organization and this the unit, they come here, and before the talk starts they get some drink, they get some snacks, and then they get to hear the latest advances in medicine, and then get rejuvenated, and within 1 hour things are over and they are back to normal. That's what the TAVI, minimalistic TAVI means. It means that a person who is, because of the aging process, has got severe aortic stenosis, he's been struggling in his life, he goes to the cardiac surgeon, he says that I can't operate you because you are 75, 80 plus, you have got so many comorbid conditions, general anesthesia will be very, very risky, and we can't do an open heart surgery. But the man is otherwise fit, he wants to get operated, he wants to live his life, he wants to lead a normal life. What we do is, under sedation, while we are talking to him, we can change the valve through a small hole in the femoral artery or axillary artery, wherever the access allows. And under local anesthesia, the magic is over, and he can get over this, and within 72 hours he's back to normal life. So that is what minimalistic TAVI is. It means that we don't put him under general anesthesia, we don't put any scar on his chest, we don't cause any trauma to his body, but his valve is changed. So that is what minimalistic TAVI is. It means that the valve implantation, which had to look for anesthesia clearance for the big surgery, that is all over. So in fact, we have in 93, 94 years otherwise physically fit. So India is aging, and it's aging healthy. So more and more people. So last week also we did 90 plus patients, and one of them was real doctor from our community, from DK2, and general physician who is retired otherwise, and then we had another professor retired of IIT who also went for TAVI. 10 years back, I had implanted a pacemaker, his wife also angioplasty and pacemaker. And then over the years, I told him that in your lifetime, probably you may not need any intervention for aortic valve. But he had COVID, and post-COVID, the degeneration of the aortic valve had gone rapidly fast, and then he needed valve replacement. So obviously at the age of 94, nobody would do open heart surgery for him. And we did the TAVI, and next day he was in the room, and then he was discharged. So I think that is something which is what we call miracle of the modern treatment. So if you look at the prevalence with aging, 1 in 8 people over the age of 75 years are affected with severe aortic stenosis, and aortic stenosis is an insidious disease. It's not that one fine morning you will have aortic stenosis. So aortic stenosis is a life-threatening valvular heart disease, and most commonly occurring in elderly owing to age-related aortic calcification. So this is what the problem is, that it happens over the years, and people feel that if they don't get their echocardiogram and other evaluation done, they might feel that probably it is because of the aging process and they are going to slow down. But believe me that once you diagnose the severe aortic stenosis, like this doctor which I was talking about, he was a general practitioner, and his ejection fraction had dropped because of the severe aortic stenosis to 25%, and he had low flow, low gradient, and we treated. And then next morning after the procedure he felt so good and he messaged me that, I'm back to normal, thank you very much. So I think that's the beauty of the whole procedure. So if you look at the aortic stenosis, it is something which is definitely the age-related problem. And if you see the valve, this is how a normal aortic valve would look like. So you can clearly see that the valve is opening very nice and, is quite complete openings, almost 4 to 6 centimeters square. So over the years, it starts narrowing, and you can see that there's a lot of calcium deposition and all. So the orifice becomes narrower and narrower, and this is how a severe aortic stenosis would look like. The valve is thin-horn, and it would need some treatment. And then the patient has got certain factors which increase the risk of developing aortic stenosis, is same as the coronary artery disease, like if the age is more than 65, if the patient has comorbid conditions like if he is diabetic, hypertensive, smoker, so all those risk factors which is there for coronary artery disease would affect him. So like chronic kidney disease, coronary artery disease, so all those things where the coronary calcification increases, similarly the aortic valve calcification would increase and can cause these things. So what are the characteristics of a TAVI patient? So patients are, basically, sometimes the patient would have severe aortic stenosis which are symptomatic and asymptomatic. So in asymptomatic, most of the patients who claim to be asymptomatic severe aortic stenosis, if you elicit the history, if you go into deep dive into the symptoms of the patient and elicit that, what are the problems, then you will find that, almost 70% of asymptomatic, so-called asymptomatic severe aortic stenosis patients would be, symptomatic. So the patients would have, severe symptomatic aortic valve stenosis, old age patients, frail, they would be frail because of the aging process is heavily calcified aorta, fatigue, slow gait and reduced ejection fraction. As I was saying, this gentleman who we did last week was having all these characteristics. So the patient should have history of atrial fibrillation, the history of syncope. So the retired professor of IIT also had a similar problem. We had put him on a pacemaker for 6 sinus syndrome, and then prior chest radiation, history of coronary artery disease, renal insufficiency, diabetic, hypertension, and peripheral vascular disease. So these are the classical things which we find. So we need to do a heart-in concept. So what we do is that the echocardiographer, the cardiac surgeon, the interventional cardiologist all sit together and take a call on this, that can this patient be operated or we can do, like a Minimalist TAVI. So we need to, do a CT coronary angiogram. We need to, like this is a patient who has the cardiac surgeon wanted to do an AVR, but the CT coronary and CT aortogram showed that there's a porcelain aorta. So in this case, you can't really put a clamp anywhere. So this patient would need a TAVI. You can, so this is a situation where the surgeon cannot really, dare to clamp the aorta and do an AVR. So frailty is another problem. Like a lot of patients, as they would go, you see that they look so frail that you feel that probably they will not be able to stand the general anesthesia. So there are, it's not an intuitive thinking or logistically when you think that it is superior. It's not just that. You have got a lot of data. We look at the tests like hip strength, walk test, and the protein values and all. And then onset of symptoms marks with severely reduced survival. So if you see, it is more serious than many of the cancers. Approximately 50% of untreated patients with severe aortic stenosis will die within 2 years of experiencing the symptoms. So we should not take it lightly. The patient could be looking overall okay, but if the patient has got severe, symptomatic aortic stenosis, the survival is not more than 2 years. And then, how to diagnose it is very easy. You can easily put a stethoscope and you can hear a very harsh sound on the chest of the patient. So this is the place where you can see the systolic murmur, and it's one of the severest, loud intensity murmur where you can't really miss it. So we need to, do clinical examination, and beyond that also we can see that the patient has got, put the stethoscope, but we don't in current age, we don't do that. So we need to look at whether this harsh sound is because of the aortic stenosis, pulmonary stenosis, or tricuspid regurgitation, or mitral regurgitation. So in that case, we can do a special examination, we can do an ECG of carotid hypertrophy, we can do the other tests like the most important and the clinching diagnosis is by what we call ultrasound of the heart or what we call echocardiogram, and with the echocardiogram we can clearly find out whether the valve is stenosis and is there any patient has got severe or mild or modest. So you cannot say that the severe aortic stenosis you can diagnose only by the intensity and loudness of the aortic murmur. So murmur may be very harsh and very loud, but that would be because the acoustic of the properties of the murmur. It may be, the severest of the aortic stenosis may be, very mild murmur or silent murmur will be there. So we need to diagnose it. So heart team decides the approach where we need to, what is the plan, how should we go about it. So what we do is that it is called STS score, based on the the Thoracic Society of Cardiac Surgeons. The decision whether the patient would, if he goes for general anesthesia or surgery of the aortic valve, will he survive it? So if this, if the patient is high risk for surgical aortic valve replacement, then obviously he should not go for that, and he should go for what we call valve TAVI procedure. So one of the reasons why we don't go for plain balloon valvotomy, which is the first step of TAVI, like in mitral valve we do a balloon mitral valvotomy, but for aortic valve within 6 months almost 60 to 65% there is a risk of restenosis in the aortic valve. So we don't do that because within 6 months the patient will come back. So balloon aortic valvotomy is just as a bailout procedure. If the patient is very sick, his ejection fraction is very low, then what we do is that in stage 1 we open the valve with balloon aortic valvotomy. And remember, if you do the balloon aortic valvotomy, a lot of them will develop aortic regurgitation which may not complicate it. So the patient would need immediate surgery. So that is why we don't encourage, because if the AR happens, it is better to go for put a valve so that the leakage is not there. So if you see, it is most commonly what we do is that the most common group, more than 85% of the cases we do with the transfemoral, but we can do what we call trans aortic also. We can do subclavian vein, subclavian arteries route also. But when you compare with the surgical aortic valve replacement, where you open the chest, remove the old valve and put the new valve, and it is seen that it is a good procedure. So consider that if the patient does not have a high risk of general anesthesia and the comorbid conditions are not there, like I described a couple of patients right now which we did last week also. They were 90 plus, they had pacemaker, multiple comorbidities. So obviously they would not come out of general anesthesia. So you might have to put them on what we call tracheostomy, and then they will be bedridden, and then the problem will be there. So the key in these elderly patients is to mobilize them early. So if you are doing a big surgery, early mobilization is out of question. So that's the reason why in these groups we try and do a shorter procedure, less pain, short stay in hospital, certain recovery time when compared to surgical aortic valve replacement. So that is the reason why, if you look at the data, that again shows that superiority of TAVI procedure compared to the surgical aortic valve replacement in these group of patients. So TAVI is superior to not only in high risk group also, but also in intermediate and low risk patients. Means that if the patient has got, his patient is relatively young, 65, 70 years, if his surgical risk is low, but in those situations also, if the anatomy is suitable, the patient will walk, next day. I had these two patients, his son was in Singapore, and he said that, I'm really amazed at this procedure, that by the time I got my tickets done, my father was at home. So that's the amazing thing about this procedure. So you can really vouch for it. But having said that, we say always that if you have got a hammer, the whole world should not look like a nail. So it means that you need to evaluate the patient well. He should not have an anatomy on CT angiogram that the aortic the coronary anatomy is not suitable, if the patient has got triple vessel disease, if the patient's coronary ostium is less than 10 millimeter at height, so that the risk of coronary occlusion is not there. And then once we are there, then obviously is the procedure which we should look forward to. So if you look at the partner trial and the core valve and evaluation trial, they all show that the more beneficial than standard therapy in patients who are inoperable. But when we look at the patients who are also, in high-risk patients, there also it is far more superior. If you look at the patients who have got intermediate risk, there also the risk outcome was significantly lesser. And now we have got the newer valves from Edward Sapien 3, and then we have got Evolute platform, the Evolute Pro, and all those valves have got skirts around it, so that the risk of paravalvular risk, now we have been implanting it in what we call cuspal overlap view, so there the risk of complete heart block and need for pacemaker is also significantly lesser. So that makes it really, really attractive, and 2 years and 3 years outcomes are really good. So in this situation, I think TAVI provides not only short-term quality of benefit, but also the long-term. So one of the questions initially was that will the TAVI valve or percutaneous valve implantation last long enough as the surgical valve? The answer is yes, it lasts even longer than the surgically implanted valve. The reason being that we don't really, the patient processes mismatch is significantly lesser in percutaneous valve implantation compared to the surgically implanted valve. So the overall survival is, or the valve longevity is, if we look at the data, almost 10 years plus, almost 14, 18 years is there. And then, so if you see the long-term benefit is also significantly in this patient. So, so what should we do? So the message is that if you have a patient at risk of aortic stenosis, you need to take the following steps. You need to listen, you need to suspect that if you listen and if you see that the patient has got murmur, you need to suspect that the patient has got aortic stenosis, and then after echocardiography, it should reach us so that we can treat, the patient gets benefited. So what we need to know more information about the aortic stenosis, I think we have distributed some booklets also. So let's look at the cases, the difficult cases like, bicuspid aortic valve, which was once upon a time was considered a contraindication for TAVI. Now this has become, our almost 45% of the patients are bicuspid aortic valve, and we have got really good outcomes. Also, if you look at the different registry and data, that clearly shows that we can implant, not only implant, but we have been doing it on a regular basis. And for some reason, in Oriental countries and in India, the bicuspid aortic valves are much more hard. So the reason why initially we did not want to do in bicuspid was the reduced perimeter, higher sealing zone, higher pacing rate, and higher paravalvular leaks were there. But now with the experience, we can see that it's not easily doable. The long-term outcomes are really good. So if you see, now I will go to the, what we call some cases where we can, because this is not something which we need to. So this is how we cut down approach, but now we have gone into completely percutaneous approach. We don't make any scar, we immediately puncture and go even in subclavian routes that can be done. So this is a patient who has had a 75-year-old gentleman who reached some other hospital and had severe aortic stenosis, has circumflex disease. So they fixed the circumflex stenosis and felt that probably that will take care of the symptoms, but that did not happen. Then he had got severe breathlessness, so we did a CT cord. So remember, when we do a TAVI, we always do a CT aortogram and to look for the size of the vessel, and also for the valve stenosis and various parameters. We also look at the coronary heights. If they are less than 10 millimeter, then we need to protect the coronary so that they don't get blocked. So in this case, we did it under transcervical guidance because we needed to give less contrast also. So this is a place where we have done a balloon dilatation of the valve, and then we did after the balloon dilatation, what we did is that is a balloon inflator valve. We implanted it. In post implant, you need to look at the heart, so we do an echo on site. So we saw that the patient had, reduced contraction of the heart, and then we realized that probably the patient has the calcium has gone into the left main and the artery got blocked. So in that case, on CPR, we opened up the artery. But this is something which is really, really uncommon. If the coronary artery is, height is okay, it doesn't happen. But this is something where we did so fast that before we out of putting intravenous and circulatory support, the patient artery was opened and the blood flow restored. And by the time the things were being getting ready, the left main got opened and stent was there, and the patient survived and doing fine. So I think this is the beauty of the TAVI valve, but we need to anticipate these things. This is another patient who has had a previous, almost 25 years back, he had a mitral valve replacement, and after that he had a severe aortic stenosis. And that time he had to stay for almost 1 month in hospital for mitral valve replacement. So in that situation, he was just not ready to go for a surgical aortic valve replacement. So here again, we wanted to make sure that nothing goes wrong for this valve implantation. So after, when you implant a valve, in this case, there is a risk of this TAVI valve impinging on the, valve of mitral tilting disc and may need urgent surgery. But in this case, under the transesophageal guidance, we did that, and you can see that the valve implantation, we made sure that we will release the valve only when so the beauty of this valve is that you can easily retrieve it back. If there is a problem at that point, you can retrieve it back, pull it a little bit back, and then implant it there. So in this case, we did not have any problem like that, and then the valve implantation was done, and the patient is doing fine. So we did it in transesophageal guidance, and things were fine. We do, so this is the final picture of the valve. You can clearly see there is no regurgitation, mitral valve, but the prosthetic valve is also doing fine. In this situation, it is really, this patient would not have made it if he had gone for surgical implantation. And then we confirm things on echocardiography. The other patient is that, patient who has had this is a patient who has had a prosthetic mitral valve implantation, tissue valve, and within 7-8 years it was surgically done, Paramount Magna valve, one of the best tissue valve, and then within 6-7 years had got a restenosis. You can see many wires, so the patient had sudden cardiac arrest. He had gone to a mall and was brought by the medics in ambulance on ventilator and all. She had got ventricular fibrillation, so we had put a dual chamber AICD implantation, and after 5-6 years, she had a severe narrowing of the mitral valve, prosthetic valve. She had COVID also, both the time she got infected, had to be admitted, and post-COVID her valve was severely narrowed. So you can see what we did in valve transmitral valve replacement. This is an Edward valve. You can see we crossed it. So what we do is that we do the interatrial septal dilatation, then we went into the through the tissue valve into the left ventricle, and then we do the valve here, and you can see that the under the transesophageal echo. So this is the Edward valve which we have mounted on the reassembled it into the inferior vena cava, and this is the valve which has been crossed. We wanted to hit under high ventricular pacing rate so that the cardiac output can decrease and the valve can stay there. And this is the implantation of the valve. You can see this is the valve fully dilated, and this is the end result where the valve is fully deployed. So we can do this. This is the fully functional valve in mitral position. So this patient would have a very high risk if we did not do the valve in valve percutaneous procedure, because with the open heart there will be so many adhesions and all that the survival of the patient would be very, very difficult. So to conclude, I would say, friends, that this is something which is a very real, revolutionary, and in our practice, if you do coming back to the same thing that minimalistic TAVI means that you don't make much fuss, you don't need to do general anesthesia and other problems. You can straight away take the patient, do the complete planning before the patient goes on the cath lab table, and if you do a good planning and with the support of the industry, you can size it, you can get the valve and within, and the whole procedure would not take more than an hour as compared to the surgical aortic valve replacement, which takes almost 4 or 5 hours, and the patient can, if everything goes okay, the patient can be discharged next morning. So now we are going in a direction where also there is a trial going on what we call daycare TAVI. Now, there was a time when we used to say daycare angioplasty is not possible, but we are doing regular daycare angioplasty. Now we can do a daycare TAVI also, so maybe within 12, 13 hours, low risk patient can be discharged and introduced to you. Thank you very much for your kind attention.
Very nice talk and very useful explanation on the TAVI and other interventional approaches you have done. And the way you have done all the cases you have carried out in the Joe Garden and all that successfully done, and they have very good result. So we are really very proud of it, what you have done. And very well highlighted, sir. Thank you very much once again. So may I request our audience the questions on the subject.
Then you can sit down. You can take your chair.
Cost of the
एक मिनट कैन भाई अरे भैया माइक होंगे ना आपके पास और माइक होंगे ना You want to ask the question? Yeah, go ahead.
There is combined aortic stenosis and aortic regurgitation. Then this TAVI will work.
So in combination, most of the patients would have severe AS or moderate AR or moderate. So some amount of calcification is needed to get the valve holding on there. But we have done some cases where there was no calcification. And in fact, there are cases where severe aortic regurgitation alone like a bilateral aortic valve. Severe AR was once upon a time contraindicated, but now we are using without AS also, severe AR also in those cases we can do it.
Dr. Pradhan sir, take it.
If calcification is except by too much calcification, then also it can be done.
Yes, I think too much of calcification is good because that will hold the valve. Having said that, in those situations we need to pre-dilate the valve. So like if you do a direct implantation, the calcium is less, but if there is too much calcification, then also we do it on a regular basis. And that's good that the valve will hold. In those situations we need to create some space for the valve to hold. So that's also a situation where it is done on a regular basis.
Thank you. So Dr. Viveka, what a wonderful talk.
So it's 18 years now, and since the first TAVI was done, so is it now time for TAVI to be the default treatment for all severe aortic stenosis? TAVI has now become the first line treatment equal to or even superior to SAVR in high to intermediate risk patients, and now approved even for low risk patients by the FDA. So would you say that even in the younger and low risk patients, SAVR would still be the gold standard?
Yes, sir. It's a very good question. If you see in various group patients, so we will always look at the anatomy of the valve. So if the risk of complication with the TAVI is very low, then in these situations we would say that in low risk also the TAVI will be a superior option than the surgical option. But there are certain situations like the patient is low risk for surgery, but when you do a TAVI evaluation, his coronary heights are less, the access site is not good, risk of vascular complications are low. In those situations, maybe the surgery will be a better choice, but we need to, in low risk also, the TAVI has shown to have a better outcome.
To elaborate further, Dr. Viveka, long-term valve durability voice in the back. Yeah, now it's better. So, long-term valve durability in young and low-risk patients is a hot topic. So, it's very crucial for expanding the, indications for TAVI now. And what about the SVD, the structural valve deterioration? So, would you say probably the 6 years follow-up data now is very reassuring? What do you say, sir?
Yeah, so now we have got in fact 10 years follow-up data, and that clearly shows that the reason why the TAVI valve they last longer than the surgically implanted valve, that the valve to patient prosthesis mismatch, where the annulus was just 19 millimeters, so the surgeon would not be able to put bigger than 19 millimeter valve. But with the TAVI procedure, you can put a 23 valve. So in those situations, if you put a bigger valve, the chances of recurrence and restenosis will be significantly less. That is why the TAVI valve, surprisingly, they outperform the surgically implanted tissue valve. So I would say, to cut the long story short, anyone who is going for tissue valve, it is better to go for the TAVI valve rather than the surgically implanted.
Right. So, Dr. Viveka, as we know that the durability of valves is about 10 to 20 years. So, we are using the valves. Yeah. So, is it the same what we use in SEVER as compared to the TAVR?
So the material of valve is either porcine or bovine. So one of the companies, they use bovine valve, the other one porcine valve. So answering the question is that the material is same, but the handling of the valve is different. So one of the reasons why the calcium treatment of the valve and the preservation of the valve and then handling of the valve are slightly different in both the situation. So remember, both the valves, whether it is surgical valve or the TAVI valve, is made by the same company, like
Right.
Workers and Medtronic. So it means that they are having long experience of making this valve. But one of the biggest factors is that we don't really, put the smaller valve. So the patient requirement of the valve, the body size, surface area requirement of the valve, even then you can put a bigger valve, and then if you put a bigger valve, then the risk of restenosis and recurrence is significantly lesser. So that's the biggest advantage with the TAVI valve. We can do valve in valve also if the patient has previous tissue valve, surgically implanted, or TAVI valve. You can implant another valve and it degenerates. So in TAVI valve, we can do again when we do a repeat TAVI valve in valve, we try and inflate the aortic canvas to a bigger size by ballooning, and then we implant a slightly bigger valve so that the risk of recurrence and restenosis is significantly lesser.
So, my last two questions, Dr. Viveka. So, the biological tissue wall which you are talking about, is there any scope for improvement now?
Yes, I think that's again a good question. So there are a lot of trials and the data is going on where the artificial tissue, which is called Borotex, the Borotex valve studies are going on, because the other valves are pericardium into bovine or porcine. But the Borotex is considered to be a very long-lasting tissue. But we do not have yet a long-term data, but definitely that will be the future. So there is definitely scope for it.
So we talked about the valve in valve with previous TAVR or SEVER. Again, the device success rate and the mortality were almost similar with SEVER or TAVR. What do you say, sir?
Yeah, so it's look at the acute complication rates. So the hospital stay, scope, and the disability, they were significantly lower. Whereas if you compare high risk, intermediate risk, and low risk, in all these three groups, it was significantly lower in TAVR group. So definitely on those accounts, it was superior. But when you look at the intermediate and low risk group, there after a year or two, once those patients survive the surgical onslaught, once they are stable, survive, then they would match the TAVI. So in TAVI group, the initial attrition rate is significantly lesser. So that's the biggest advantage.
So my last question is, how long do you continue with anticoagulants?
So we don't, so that's a very weird thing that the surgeons, even if they are putting a tissue valve, they give anticoagulants for 3 months. But when we do TAVI, we don't give anticoagulants at all. We just be doing the procedure. After that, it's just the dual antiplatelet.
Wonderful, sir. Thank you.
Sir, wonderful presentation on TAVI. You are one of the opinion leaders and operators on TAVI. My question is, if you had a patient with a mechanical valve implanted, and then this mechanical valve, the gradient increases gradually, will this patient qualify for a minimalistic TAVI?
Yes, I think that's a good question. So when the the mechanical valves are there, so by default they are made of strong metallic material. So that will not be a choice for TAVI. So that will be an off-level use. So in order to qualify for that, you need to break the metallic frame. So it's an uncontrolled procedure. So that is why it's not a default choice for TAVI. Valve, mechanical valve. For tissue valve, so that is why we are moving in direction of tissue valve. So even if the patient is younger, you can do valve if the patients. Because remember, one of the downsides of the metallic valve is that the patient has to be on oral anticoagulant, and oral anticoagulant is again a disease in itself. You need to not only check. Unfortunately, the newer oral anticoagulants, no, as well, you don't need to do ETINR and all, and the anticoagulation is absolutely marked. Although they have miserably failed in trials. So you need to depend on the vitamin K antagonist. And for that reason, a lot of patients would have variation in the INR. Some of them would have valve thrombosis. Some of them would have bleeding complications. So the attrition rate is almost 5% annually. Many patients will succumb to that. So the answer to your question is that if the patient has got mechanical valve, then you cannot do TAVI unless you try and do that, something is better than nothing. So in that situation, we can do, supravalvular implantation, we can, through the valve, but that's something which is just the case report, it's not the standard practice.
Sir, the presentation was on minimalistic TAVI. And we know that TAVI in max costs around 20 lakhs, if I'm not mistaken, or maybe more. Does minimalistic TAVI cost minimum, or is it just a misnomer?
No, so the cost-wise, I think if you go for the Indian valve, we can come down up to even 12 to 13 lakhs rupees. So there are a couple of Indian companies which has come up. And the cost of the international valve, also the Medtronic and the Revolut has come down to 20 lakhs, which once upon a time it used to be 30 lakhs, 32 lakhs. So I think minimalistic TAVI is not about the cost, it is about the minimal stay of the patient in the hospital, minimum requirement of the support, no minimal scar. When we say minimal TAVI, that means that the patient does not have to stay for more than a day, patient does not have to be under the anesthesia, patient doesn't get any scar. So that is what minimalistic is. And obviously as the volume grows, there are a lot of many companies. So right now in India, at one point we had only 1 or 2 companies. Right now we have got 7 companies with TAVI valve. You can imagine when the competition goes up, we think that probably the BCCI and the government also wants that it should be priced at around 5 to 10 lakhs, so that will be affordable to everybody.
Sir, my next question is about the permission for TAVI. I understand that if you have to have a CGHS beneficiary being operated under TAVI, there is a board, which the government needs to set up, and they need to give permission for TAVI. Even for minimalistic TAVI, the same is true?
Yes, I think it boils down to rationalize the government's resources. So unless, because you are comparing with 3 to 5 times higher cost, so even if you use the Indian valve, it will be around 4 times the surgical cost. So we need to, the criteria has been made that if the patient has risk of surgical death is more than 8 to 10%, then only the permission for TAVI valve will be given. So meaning thereby that, but even a patient who has had a risk of dying of 1% during a successful calculation may have only 7 can die during surgical implantation or vice versa. So the likelihood of benefiting or having complications, the more the risk of complication during the surgical valve implantation. So that is why the approval has been reserved for people who are at a very exorbitant high risk of surgical mortality during the open heart surgery. So we have shown the data that almost 30% of patients remain unoperated because of a very high risk of surgical mortality. So with this institution of this therapy, that gap is easily bridged and probably more and more patients can live longer.
Sir, my last question is, we often hear and understand from your talk that NOACs are not the drug of choice for valves, for valve conditions. I always wonder why, sir. So, do we have an answer to that?
Yes, I think that's again a good question. So it's NOACs have been shown to work on the natural tissues, but they have not really been shown to work on a foreign body metallic thing. So by default, if you see all the tissue valves, so there we give NOACs if the patient has got need for what we call, if the patient has got atrial fibrillation or other causes, deep vein thrombosis, we give the NOACs and they do very well. But the patient so there are multiple mechanisms working on that, and it has been postulated that NOACs will never ever be successful when you took a metallic valve prevention of thrombosis with the NOACs, simply because not only the factor 7, 8 and 10A they work, because if you look at the NOACs they would work on that only, but it works on the the antiplatelet mechanism and the other issues are also there. So you need to have something which works on all those cascades, and probably that's the reason why with the metallic valve the NOACs are not the answer as well. So unless you combine something with the NOACs, there is a trial which is going on where NOACs plus antiplatelet and things probably will work, but that puts the patient at a very high risk of bleeding also.
Thank you very much. I am sure there are more questions.
Sir, I have one question, sir.
Yeah, I am coming to you, Dr.
Last question, sir.
Sir.
Thank you, sir. Thank you very much. Sir, TAVI, very important procedure. And who will done this procedure is very important intracardiologist procedure. Dr. Viveka, sir. My question is, sir, in this forum, TAVI lecture or seminars, so many seminars we are having. But complications about the TAVI, we have never discussed, never asked the questions. Complications in TAVI procedure. My first question is, when TAVI performed after 7 days, 10 days, 8 days, 20 days, there is a bleeding from the wall, number 1. Number 2 is displacement of the valve. After some time, what do you say, sir?
Yes, I think that's a very good question. That is what we meant by risk stratification of the patient. So suppose the patient has the risk factors. So that is why we do a CT aortogram of the patient. And the CT shows that there are predictors of high risk of complications. Suppose the coronary, like the first case I showed, the patient coronary height and everything was okay on CT, but had a large chunk of calcium that went into the left main, and left main got occluded. Fortunately, we could stent the left main and the patient saved and doing fine right now. So one complication is coronary occlusion. Second thing is the patient has got a lot of calcium. When you implant the valve, the calcium can get and leakage in the rupture of the aortic annulus, and the patient might need immediate surgery. So it is a foregone conclusion that is why the hybrid team is so important, that the cardiac surgeon should be available on site. It is unfortunate that there are few centers who do 1 or 2 TAVIs without the surgical backup. But ideally we should have a surgical backup. So as you rightly said, that there are few patients who might need emergency surgery. Third thing is that there are patients where, when you are handling the wire and all, there may be perforation of the, heart, left ventricle and all. So you need to surgically repair that. So those are the complications. And then obviously the site, the place from where you are doing the, taking the valve and all, there may be some complications of increased bleeding or occlusion of the artery, where you need to do angioplasty in peripheral artery so that the blood flow is maintained. So I think you are very right that we need to be mindful of the complication also, and that is why when we evaluate the patient, we look at these what we call risk for complications, and if the risk of complication is significantly lesser and the benefit is huge, then only we say that this patient should be taken for TAVI.
What about the displacement, sir?
Displacement acutely it may happen, but it has never happened. So if you have implanted and
But
chosen
it
the
reported,
right.
sir.
No, that's what I'm saying. That if the patient, when you are doing over or undersized valve, or if you are doing something where your valve during the, if you have not decreased the mean blood pressure to less than 50, valve may pop out. We call it pop out of the valve. In that situation, you can put another valve, which is, which can be implanted right at the annulus. So you can do. So initially, when the TAVI procedure started, company used to give 2 valves per patient, so that if one valve comes out, then you can implant the another valve. But now, with the current technology and with the more mature technology and experience, the valve migration and pop out is very, very rare. It has never happened to me. I'll say.
Thank you, sir. सर मेरा क्वेश्चन पूछने का मेरे को ऊपर करना चाहिए सर, ये लास्ट में मेरे को दिया जाता है, मेरे को पहले दिया जाता है.
Very wrong. You are supposed to ask every question all the time whenever you feel like. There is no discretion. Everybody can ask questions here, and everybody is free to ask.
Yes, yes. Sir, what I am doing is, I am arranging a dangle between you and Dr. Tulsi. Next Wednesday.
सर मेरे तुलसी साहब से हार गया.
जब देखिए सुनिए.
मैं पहले ही हार गया.
मेंटल दंगल, फिजिकल दंगल. चलिए. No, good. Sir, good. आप समझ गए, आप समझदार.
Thank you, Dr. Singh, for your question, and thank you everybody for taking active participation in the forum activities. I would like to thank once again to Dr. Viveka for a lovely talk, highlighting the role of TAVI and highlighting the uses of TAVI in the time today. And it was really enlightening to all of us that what we have heard today. I think there are no more questions. I thank once again to Dr. Viveka for her. Thank you so much.